Neonatal Resuscitation. Introduction. Neonatal resuscitation skills are essential for all healthcare providers who are involved in the delivery of newborns. Neonatal transition requires spontaneous breathing and successful cardiopulmonary changes, as well as other changes to independent organ system functions. The current infant mortality rate for India in 2022 is 27.695 deaths per 1,000 live births, a 3.74% decline from 2021. Intrauterine to extrauterine adaptation. Short review. Respiratory adaptation. In utero, most of the blood flow is shunted away from the lungs and directed to the placenta where fetoplacental gas exchange occurs. After birth, the airways and the alveoli must be cleared of fetal lung fluid so that the lungs can operate as a functional respiratory unit providing adequate gas exchange. The placenta provides the respiratory function for the fetus. The placenta has a multivillous circulation that provides the maximum surface area for the exchange of oxygen and carbon dioxide between the mother and fetus. Several factors result in the lowering of maternal pH and increasing of fetal pH, which results in increased transfer of oxygen from maternal to fetal hemoglobin or red blood cells, RBCs. Fetal breathing, chest wall and diaphragmatic movement begins at approximately 11 weeks gestation and increases in strength and frequency throughout gestation. At term, the fetal lung is filled with approximately 20 ml of fluid. After birth, lung fluid is removed by several mechanisms, including evaporation, active ion transport, passive movement from Starling forces, and lymphatic drainage. The first breath must overcome the viscosity of the lung fluid and the intraalveolar surface tension. This first breath must also generate high transpulmonary pressure, which helps drive the alveolar fluid across the alveolar epithelium. Pulmonary blood flow must increase, and spontaneous respirations must be established. Fetal pulmonary vascular resistance is high, and the fetal systemic vascular resistance is low. Within minutes of delivery, the newborn's pulmonary vascular resistance may decrease 8 to 10-fold, causing a corresponding increase in neonatal pulmonary blood flow. At birth, the lungs must transition rapidly to become the site for gas exchange, or else cyanosis and hypoxia will rapidly develop. Cardiovascular adaptation. The fetal blood reaches the placenta via the umbilical arteries. Well-oxygenated blood from the placenta is returned by the umbilical veins, about one-half passing through the liver sinusoids, and the rest bypassing the liver via the ductus venosus into the inferior vena cava system. The blood then passes to the right atrium. Since the inferior vena cava also receives deoxygenated blood from the lower portion of the body, the blood entering the right atrium is not as well oxygenated as that in the umbilical veins. The minor circulation through the lungs. Although existing anatomically, the minor circulation is almost completely short-circuited by two major mechanisms. The blood from the inferior vena cava is directed largely by the lower border of the septum secundum, through the foramen ovale, which directs blood from the right to the left side of the heart. Some oxygenated blood from the inferior vena cava stays in the right atrium, mixes with deoxygenated blood from the superior vena cava and coronary sinus, and passes to the right ventricle. Blood leaves via the pulmonary trunk and passes through the ductus arteriosus, which diverts it from the pulmonary to the aortic system. Circulation at birth. Placental circulation is interrupted. The abrupt drop in intrathoracic pressure brought about by the first respiration, aeration of the lungs, helps contribute to the initial pulmonary circulation. Blood pressure decreases in the pulmonary artery even though its flow is increased, since it supplies a capillary network considerably enlarged by expansion of the pulmonary parenchyma. As a result, blood flow decreases, even reverses momentarily, in the ductus arteriosus. Its valves contract, and in a few days, it closes off completely. Similarly, influx of pulmonary blood into the left atrium causes the septum primum to be pressed against the septum secundum, and the foramen ovale is closed. The umbilical arteries also constrict at birth and prevent blood loss. Fibrous degeneration of the ductus arteriosus forms the ligamentum arteriosum, between the left pulmonary artery and the concave inferior surface of the aortic arch. Complete fusion of the septum primum to the septum secundum forms a definitive interatrial septum. Traces of the former passage, the foramen ovale, are seen as a depression, the fossa ovalis, in the right interatrial wall. Neonatal resuscitation. Definition. NNR, neonatal resuscitation, is a simple, inexpensive, cost-effective method. The goals of resuscitation are: to assist with the initiation and maintenance of adequate ventilation and oxygenation, to maintain adequate cardiac output and tissue perfusion, and to maintain normal core temperature and serum glucose. Successful NNR factors. 3A's. Anticipation, adequate preparation, accurate evaluation, algorithm-based. Anticipation, high-risk delivery, maternal condition, advanced maternal age, diabetes mellitus, hypertension, stillbirth, fetal loss, early neonatal death. Fetal condition, prematurity, post-maturity, congenital anomalies, multiple gestations. Antepartum complications, antepartum hemorrhage, oligopolyhydramnios. Delivery complications, malpresentation, meconium-stained amniotic fluid, MSAF, instrumental delivery, antenatal asphyxia with abnormal fetal heart rate. Recommendations for anticipating resuscitation need. Every birth should be attended by at least one person who can perform the initial steps of newborn resuscitation and initiate PPV. Before every birth, a standardized risk factors assessment tool should be used to assess perinatal risk and assemble a qualified team on the basis of that risk. Before every birth, a standardized equipment checklist should be used to ensure the presence and function of supplies and equipment necessary for a complete resuscitation. When anticipating a high-risk birth, A pre-resuscitation team briefing should be completed to identify potential interventions and assign roles and responsibilities. 2. Adequate preparation. The delivery room should be equipped with all the tools necessary for successful resuscitation of a newborn of any size or gestational age. The equipment should include a radiant warmer, warmed blankets, a source of oxygen, instruments for visualizing and establishing an airway, a source of regulated suction, instruments and supplies for establishing intravenous 4. access, trays equipped for emergency procedures, and drugs that may be useful in resuscitation. 3. Evaluation, algorithm-based. Rapid assessment of neonate clinical status. Is the infant full term? Is the infant breathing or crying? Does the infant has good muscle tone? Yes, no resuscitation, routine neonatal care. No, needs resuscitation. Temperature at birth recommendations. Placing healthy newborn infants who do not require resuscitation skin to skin after birth can be effective in improving breastfeeding, temperature control and blood glucose stability. The temperature of newly born babies should be maintained between 36.5 degrees Celsius and 37.5 degrees Celsius after birth through admission and stabilization. The use of radiant warmers, plastic bags and wraps, with a cap, increased room temperature, and warmed humidified inspired gases can be effective in preventing hypothermia in preterm babies in the delivery room. Exothermic mattresses may be effective in preventing hypothermia in preterm babies. In resource-limited settings, it may be reasonable to place newly born babies in a clean food-grade plastic bag up to the level of the neck and swaddle them in order to prevent hypothermia. Airway maintenance. Head position should be in sniffing position. The sniffing position, a combination of flexion of the neck and extension of the head, is considered to be suitable for the performance of endotracheal intubation. Clearing the airway and tactile stimulation in newly born infants. Routine oral, nasal, oropharyngeal, or endotracheal suctioning of newly born babies is not recommended. In babies who appear to have ineffective respiratory effort after birth, tactile stimulation is reasonable. Suctioning may be considered if PPV is required and the airway appears obstructed. For non-vigorous newborns delivered through MSAF who have evidence of airway obstruction during PPV, intubation and tracheal suction can be beneficial. Assessment of heart rate during neonatal resuscitation. After birth, the newborn's heart rate is used to assess the effectiveness of spontaneous respiratory effort, the need for interventions, and the response to interventions. During resuscitation of term and preterm newborns, the use of electrocardiography, ECG, for the rapid and accurate measurement of the newborn's heart rate may be reasonable. Ventilatory support after birth, PPV and continuous positive airway pressure. The vast majority of newborns breathe spontaneously within 30 to 60 seconds after birth, sometimes after drying and tactile stimulation. Newborns who do not breathe within the first 60 seconds after birth or are persistently bradycardic, heart rate less than 100 min, despite appropriate initial actions, including tactile stimulation, may receive PPV at a rate of 40 to 60 min. In newly born infants who require PPV, it is reasonable to use peak inflation pressure to inflate the lung and achieve a rise in heart rate. This can usually be achieved with a peak inflation pressure of 20 to 25 centimeters water, H2O. Excessive peak inflation pressures are potentially harmful and should be avoided. In newly born infants receiving PPV, it may be reasonable to provide positive end expiratory pressure, PEEP. Recommendations for rate and inspiratory time during PPV. It is reasonable to provide PPV at a rate of 40 to 60 inflations per minute. In term and preterm newly born infants, it is reasonable to initiate PPV with an inspiratory time of 1 second or less. In preterm newly born infants, the routine use of sustained inflations to initiate resuscitation is potentially harmful and should not be performed. For spontaneously breathing preterm infants who require respiratory support immediately after delivery, it is reasonable to use CPAP rather than intubation. Recommendations for oxygen administration during neonatal resuscitation. In term and late preterm newborns, 35-week or more of gestation, receiving respiratory support at birth, the initial use of 21% oxygen is reasonable. In preterm newborns, less than 35-week of gestation, receiving respiratory support at birth, it may be reasonable to begin with 21% to 30% oxygen with subsequent oxygen titration based on pulse oximetry. In term and late preterm newborns, 35-week or more of gestation, receiving respiratory support at birth, 100% oxygen should not be used because it is associated with excess mortality. Chest compressions. CPR timing. If heart rate after birth remains at less than 60 min despite adequate ventilation for at least 30 s, initiating chest compressions is reasonable. The benefit of 100% oxygen compared with 21% oxygen, air, or any other oxygen concentration for ventilation during chest compressions is uncertain. It may be reasonable to use higher concentrations of oxygen during chest compressions. Recommendations for providing chest compressions. When providing chest compressions in a newborn, it may be reasonable to repeatedly deliver 3 compressions followed by an inflation, 3:1 ratio. When providing chest compressions to a newborn, it may be reasonable to choose the 2-thumb encircling hands technique over the 2-finger technique, as the 2-thumb encircling hands technique is associated with improved blood pressure and less provider fatigue. Intravascular access. Recommendations for vascular access. For babies requiring vascular access at the time of delivery, the umbilical vein is the recommended route. If intravenous access is not feasible, it may be reasonable to use the intraosseous route. Medications, epinephrine, in neonatal resuscitation. If the heart rate has not increased to 60 min or more after optimizing ventilation and chest compressions, it may be reasonable to administer intravascular epinephrine, 0.01 to 0.03 milligrams per kilogram. While vascular access is being obtained, it may be reasonable to administer endotracheal epinephrine at a larger dose, 0.05 to 0.1 milligrams per kilogram. Administer further doses of epinephrine every 3 to 5 min, preferably intravascularly, if the heart rate remains less than 60 min. Volume replacement. It may be reasonable to administer a volume expander to newly born infants with suspected hypovolemia, based on history and physical examination, who remain bradycardic, heart rate less than 60 min, despite ventilation, chest compressions, and epinephrine. It may be reasonable to provide volume expansion with normal saline, 0.9% sodium chloride, or blood at 10 to 20 ml/kg. Post-resuscitation care. Newly born infants born at 36 WK or more estimated gestational age with evolving moderate to severe high should be offered therapeutic hypothermia under clearly defined protocols. Newly born infants who receive prolonged PPV or advanced resuscitation, intubation, chest compressions, or epinephrine, should be maintained in or transferred to an environment where close monitoring can be provided. Glucose levels should be monitored as soon as practical after advanced resuscitation, with treatment as indicated. For newly born infants who are unintentionally hypothermic, temperature less than 36 degrees Celsius, after resuscitation, it may be reasonable to rewarm either rapidly, 0.5 degrees Ch, or slowly, less than 0.5 degrees Ch. Withholding and discontinuing resuscitation. Non-initiation of resuscitation and discontinuation of life-sustaining treatment during or after resuscitation should be considered ethically equivalent. In newly born babies receiving resuscitation, if there is no heart rate and all the steps of resuscitation have been performed, cessation of resuscitation efforts should be discussed with the team and the family. A reasonable time frame for this change in goals of care is around 20 min after birth. If a birth is at the lower limit of viability or involves a condition likely to result in early death or severe morbidity, non-initiation or limitation of neonatal resuscitation is reasonable after expert consultation and parental involvement in decision-making.